Hello and welcome. I'm Steve Clemens, editor-at-large of The Hill. Thanks for joining us for our program today, Prioritizing the Patient, a virtual deep dive into our current healthcare landscape and how we can move the needle, so to speak, on affordable quality care. Before we begin, I'd like to thank our sponsor, Consumers for Quality Care, for supporting today's conversations. As we struggle to control a raging pandemic, it's clear that our current healthcare system doesn't serve all patients equally. That gaps and barriers exist is not news to any of us, but we use this moment to address some of the problems that have existed for far too long. Today's conversation will address inequities in the access and delivery of health care. We're going to try to arrive at the right balance of cost and quality of care, look at the social contract in the healthcare landscape, and how to put the patient at the center. We have a fantastic lineup of speakers to discuss all of this and more, including members of Congress, leading physicians, and healthcare experts. But first, a few housekeeping notes. You can tweet us at the Hill Events. It's all one word, The Hill Events, at the hashtag The Hill Patients. We're broadcasting live and we'll be taking your questions throughout the program. As with any live stream, if it goes out, they say push refresh and hopefully it will all come back. It never works for me, but I'm told it will work for you. And with that, my first guest is Congressman Larry Bucshon, a member of the Energy and Commerce Committee. Before joining Congress, he was a practicing physician. Congressman, thank you so much for joining us today. Look, our job today is to discuss if we were to put the patient at the center of the American healthcare system, as we sit in the middle of a every 100-year pandemic, it seems, what are the elements and scaffolding and the pieces that we need to address at this moment to use this crisis constructively on behalf of America's patients?
Well, first of all, thanks for having me, and I like the title of your program because as a member of Congress and a former healthcare provider, that should be the focus in government. And frequently it's on the money. So there's a couple of big picture issues, I think, is more data for the American consumer about healthcare quality. And there needs to be more transparency on healthcare pricing. Those are two big issues that if the American people had more information, they could have more input into their basic healthcare. And I've been working on a variety of issues to make that happen.
Look, we don't have a command and control system in healthcare. We have a lot of moving pieces. We have insurers, we have pharmaceutical companies, we have pharmacy benefit managers, a lot of different moving. We have providers and doctors and physicians like yourself. In fact, I want to note that you're a very active physician. Have done, I'll make a very bad joke here in a minute. You're a heart surgeon. A buddy of mine who was an ambassador talked about his former head of state once having heart surgery, and the ambassador called me up and said, "Steve, you're not going to believe it. They found a heart."
Yeah, there you go.
I'm sure you've heard that one before. But in the social contract between all these moving pieces, because we don't control all of it, are you worried that any of the elements are getting out of control?
Yeah, I mean, I think the business side of medicine right now is really taking a lot of the control operationally away from the practitioners, the providers. People that actually are in the arena taking care of the patient are being controlled by governmental agencies, their own administration at their own local hospitals and clinics. So yes, I think as a provider, from a provider's perspective, more of the focus needs to go back on the patient, number one, as is the title of your program here, but also get back to more input from at the provider level for operational control of what works and what doesn't, and quit focusing mostly on the business aspect and honestly trying to make more money for publicly held companies in some areas of the healthcare system. So I think yes, and the only way you make that happen is, as I mentioned in my opening comment, is the American consumer needs transparency in the system and so that they can assess where the money's going, what they're paying for, and on top of that, what the quality of the service they're being provided is. And we just don't see a lot of that in our system at this point.
Congressman, you have been concerned, as I understand it, with essentially the lack of the kind of data you need, information sharing in the systems, and you've introduced legislation called the Immunization Infrastructure Modernization Act. So we're sitting in the middle of, dramatic need for vaccinations, vaccines across the nation. How would this address that infrastructure?
Well, I think what we've found out is, through our public health systems, both at the local and state level, they're really insufficient structurally to handle the pandemic. And that's not a criticism of those people who are working every day to improve the lives of the people they serve. But what we need more is more of a national logistics plan to help coordinate between all of our public health services. And honestly, we need more money because we found out that as far as staffing and as far as other infrastructure like IT programs, basic things like that, it was just insufficient for this type of pandemic. And, we're improving, but we still have challenges. And so that's what I hope to do is try to address, hey, what are the problems in the public health system? How do we make them better? How do we get more money into the system and recognize the importance of what we have? It unfortunately took a crisis to show us our deficits.
One of the things we'll be discussing with another member of Congress, but other in the conversations today, is how to make healthcare outcomes more equitable. How to address parts of the community that haven't been on that track. What are your thoughts about what the right approach to creating more equitable healthcare outcomes and what that social contract ought to look like?
Well, this is a big challenge because I represent primarily a rural area of the country, and rural America and urban America have something in common. They have difficulties accessing the healthcare system, and we're finding that out with the vaccines. That the distribution of the vaccines is there, but then the fundamental healthcare related issues that people had before that are limiting their access. And it's not just in healthcare; it's their ability to access the internet. The ability to have transportation to get to their physician's appointments or to get the vaccine. So it's really a multi-pronged approach that honestly affects both urban and rural America. And I think it's a real big challenge. And I think what's happened is we've centralized our healthcare system. We've so-called Walmartized our healthcare system, where a lot of it is based in larger urban areas, in certain parts of urban areas, and we've left out some of our fellow citizens in the rural and what I'll say the more disadvantaged areas of our urban communities. And so we need to address that. One of those areas is maternal health, and I've been working on that. And surprisingly, some areas of the country have very high maternal mortality. That's where the woman dies after childbirth or during childbirth. It doesn't have to be that way, though. We heard testimony from Parkland Hospital in inner city Dallas that serves a primarily poor Medicaid or uninsured population. They have outstanding data. So what we've done is put forward legislation that would help give federal grants to spread that type of information, what Parkland's doing and how we can, bring that to other areas to improve the quality of care. The data is out there. We need dissemination of best practices so that everybody can improve the quality of care. But it's going to be a big challenge because of the way our healthcare system is structured. Again, more focusing on larger healthcare systems versus local clinics. We're going to be working on that. It's a challenge for both urban and rural America.
One of the topics I always worry about losing listeners when I raise it, but it's one of the hottest topics in healthcare, are essentially payments and reimbursements and Medicare charges and whatnot.
Yep.
And I know that you've been actively trying to both reform, try and get money going the right direction for folks. Again, putting the patient at the center of this process, opposed to becoming a yet again victim in the process. What do you think the most important things that we need to do when we look at payments and reimbursements and the dollar side of the healthcare picture for people?
Well, as I mentioned earlier, the first step is we have to have transparency. The American consumer needs to understand what they're paying for and why and where the money's going. And we just don't have that. At the Medicare level, the governmental level, and the Medicaid level, reimbursements have dropped for years. And some of that was maybe appropriate in the Medicare space. But we've got to the point now where it limits access to physicians. And I'm concerned about that. I worked on that at the end of the last Congress. Unfortunately, we got some mitigation of the proposed Medicare cuts into the omnibus bill at the end of the year. But still, we need to make sure that providers out there are appropriately paid for the services that they provide. But also, we want to avoid patients getting services they don't need, and the federal government and other payers paying those bills. So to do that, we need transparency, not only in pricing, but in quality. And this can be done, and we need to do that. The Society of Thoracic Surgeons, my society, has had a database for 25 years on the quality of care that surgeons are providing. This needs to be available to the American public. We can get the cost of healthcare down, but we have to have the patient at the center of this, and they have to have the information necessary.
Congressman, if President Biden gave you a call tonight and said, "Hey, I know you're a physician, you're a doctor, heart doctor. I know we're not in the same party, but what are the most important guardrails you think I need to be aware of as they roll out? Dealing with the Affordable Care Act, dealing with healthcare, dealing with how you get more people covered." What would you tell him?
Well, again, I know it sounds like a broken record, but I would tell him that we need transparency on the business side of healthcare.
Right.
And so that the American consumer understands what's happening. And we need more transparency on the quality. I mean, and that can be done. But the business side of medicine is a difficult nut to crack because it's very complicated and there's people doing things the right way. But the system's become so big that the American consumer is no longer at the center of it. And
right.
You really, if you walked into a hospital today and say, "Hey, how much is it going to cost me to have my gallbladder taken out?" They would tell you, "Well, it depends. We don't know." I've always said you can go to the worst heart surgeon in the country or the best, and if they have a Medicare patient, they get paid the same. Well, that's not that way in any other business where poor quality work gets reimbursed at the same level. So we need to assess that. But again, I would tell the president, let's work towards transparency in the business side of healthcare, and let's look towards more quality data being presentable to the American people in a way that they can understand.
Congressman, we're out of time, but I like you being a broken record and talking about transparency. I get the message and the importance of it, and I think one of the things that's happening out there, you've tweeted about it, is the question of surprise medical billing and how do you prevent patients from running into those moments, but also how do you protect the equities of health plans? That seems to me solvable, but it's a big issue out there. Do you think it's solvable?
Yeah, I mean, I think what we passed at the end of the year that got into the omnibus, a solution for now for the surprise medical billing situation is going to help. And I think, again, it's about transparency. Let me just tell you, your viewers, what happens. You go to the hospital. Yesterday, your physician was in network, but that changed overnight, and you didn't get that information. So you go to your physician. Next thing you know, you get a bill, for a bunch of money, and you're saying, "What happened here?" Well, there was no information transmitted to the consumer, so they could make that decision. Hey, my physician's not in network. So we've basically solved that problem by balancing the interests of the patient, number one, taking them out of the picture so that they don't owe any money for this type of mistake, but also making sure the provider gets reimbursed at a fair rate that doesn't overburden the insurance companies. So I think we've struck a pretty good balance on that issue. Well,
Congressman Larry Bucshon, who's maybe a physician first, congressman second, maybe the other way around, from Indiana. Thank you so much for joining us today. I hope you'll come back. I know we're going to be at this issue all year, and I think putting patients first is a vital frame for this. So thanks for being so enthusiastic about it and joining us today.
You're welcome. Thanks for having me. I'll come back anytime.
Excellent. And now a message from our sponsor. Please welcome Jason Resendez, the Executive Director of Latinos Against Alzheimer's Coalition and board member of Consumers for Quality Care.
Thank you, Steve, and good afternoon, everyone. I'm Jason Resendez, a board member with Consumers for Quality Care. We are a coalition of patient advocates, former policymakers, and health advocacy organizations working together to lift the voice of patients as they demand access to high-quality, affordable healthcare. I would like to thank everyone for joining us this afternoon, especially the members of Congress who've made time to share their insights on this critical topic. We are here today to bring together the healthcare sector with patient advocates to talk about moving the needle towards affordable and accessible high-quality healthcare. We will share findings from new research released today by CQC in collaboration with ALG Research and Public Opinion Strategies on consumer attitudes towards the healthcare system in the midst of our current pandemic. I am pleased to be joined by fellow CQC board member Jim Manley, who will discuss some of the research findings with John Anzalone and Neil Newhouse. Jim is a seasoned Capitol Hill veteran, having served as spokesman for then Senate Majority Leader Harry Reid in the Senate Democratic Caucus. Over to you, Jim.
Thanks, Jason. It's a pleasure now to be joined by two of the nation's top pollsters to discuss their research for CQC on how COVID-19 has shaped consumer expectations for healthcare coverage, cost, and quality in 2021. Let me first begin by introducing John Anzalone, the partner and founder of ALG Research. John has polled for numerous presidential campaigns and was most recently the chief pollster for President Joe Biden. I'm also joined by Neil Newhouse, partner and co-founder of Public Opinion Strategies. Neil has polled for multiple Republican presidential campaigns and was the lead pollster for Mitt Romney's 2012 presidential campaign. Once again, let me say thank you both for being here today. Let's begin by saying that, unsurprisingly, COVID-19 has had an impact on consumers' opinions on healthcare. Your research found that while cost still drives the healthcare debate, the barriers that lead to skipping and delaying care, like high healthcare deductibles and programs that increase access to healthcare, like telehealth visits, are extremely important to voters looking to navigate the healthcare system. Let's dig into some of those findings with a few questions. Neil, let's start with you. How are Americans feeling about the healthcare system and the industry as a whole as it pertains to the response to COVID-19?
Jim, that's a loaded question and a complicated one. If you look at this data and you go through the entire polling, Americans are really mixed. First of all, they think we, having gone through COVID-19, the healthcare system is extraordinarily fragile. It's complicated. One voter says, "I'm surprised at how quickly the system could reach its limits." You think it's a massive thing, but it's actually fragile. So it's the fragility of the system, but it's also the resilience. Americans believe that the healthcare system came through this really with flying colors. They came away with a new respect for healthcare workers and the system itself, the way it bounced back. But Americans are still of the mind that major changes need to be made. But it's a complicated question, and voters are really of kind of two minds about how they feel about it. Everybody's got a healthcare story to tell. It is right up there with COVID-19 and the economy. It is part and parcel to those two issues. If there's a triumvirate or three-legged stool of issues facing the country, it's certainly healthcare, COVID, and the economy.
And I think that, Neil and I have worked a lot together. We've done a lot of focus groups together. And first off, in some ways, healthcare is part of all of them. COVID is a healthcare issue. As we've seen, people view the system being stressed, but also the system being resilient. When you take a look at the economy, a lot of times when you ask what is the biggest economic anxiety that people have, it is healthcare. So even the economy is very tied into their healthcare concerns. And of course, then there's just healthcare and there's costs. Quite frankly, the narrative on healthcare hasn't changed pre and or during the pandemic and probably post, which is cost. Costs are a big problem with people, and that was the same pre-pandemic.
69% of voters we talked to said they feel like insurance companies are nickel and diming them to death with all the out-of-pockets. 51% say they worry about being unable to afford a high deductible for care they need down the road. 46% say they're concerned that right now they may have to delay medical care because they can't afford out-of-pocket costs. It's those kinds of concerns that really jump out of the survey and make this data and this survey different from other stuff we've done in the past.
And Neil and I actually started picking this up a couple of years ago when we were doing some work together on healthcare in the focus groups, where we get people in a room and we talked to them. We also did some call boards, which were an online focus group for this study. And when you get into conversation about healthcare, it's now almost all about what Neil talked about, the nickel and diming, the co-pays, the deductibles, all that type of stuff. Every time you go to a pharmacy, every time you go to a doctor, if you happen to go to a hospital emergency room, if you have to go see a specialist, again, deductibles are too large, co-pays are too large. So everywhere they turn, there's a little bit more money. And what do they say? Well, why is my insurance picking this up? And so there's also another dynamic which over the years, and this is real, employers have started pushing more and more premiums on people. So people are feeling very stressed in terms of the little stuff, which adds up to big stuff, the co-pays, the deductibles, as well as them having to take a little bit more burden for their own premiums from employers. So they're feeling the heat, and it's real.
And what this does, this goes back and it becomes an economic issue. It's why these three issues, COVID, the economy, and healthcare, are all linked together. It ties right back into the economy and making ends meet for families.
Interesting. So let's take a step back, kind of a broad brush question. Are people willing to trade quality for lower costs?
Nope. No, it's and in fact, throughout the survey, Americans really don't have a problem with the quality of care they're getting. They want it all. They want low cost and high quality. It's probably impossible to do both, but they are not willing to trade off the quality of care for a lower cost product.
Neil, the pandemic has obviously caused many Americans to adapt in different ways, and many of us relying on technology a heck of a lot more in our day-to-day lives, including myself, to work, to learn, etc. Can you tell us about telemedicine and telehealth?
Yeah, it's Americans have embraced it. They've done it. They like it. They want to continue it. It's here to stay. This is nearly 7 in 10 say they are likely to use telehealth after this pandemic is over. I mean, the pandemic has changed not just how we receive healthcare, but how we work at the office, how we do conference calls, how we do briefings, and it's changed the way we receive our healthcare. Americans have embraced it, they like it, and they want it covered.
And I think that this is one of these issues. I think it's good for both ends. I think it's good for doctors and healthcare professionals. And physicians' assistants, and I think it's going to be good for the consumer, especially with more and more households where both parents work, and taking a kid to a doctor can be often difficult, and often you make that decision of whether or not to take them. So telemedicine not only has a majority of Americans in our poll used it in one way or the other, physical and mental, but also for those who have used it, there's a 2/3, I believe, give it very high ratings, and most people are willing to go back and prefer it. As a matter of fact, a plurality of people who have used telemedicine actually say they prefer it in the future.
I know that it's worked for me. Thanks, folks.
Thank you, John, Neil, and Jim. To learn more about the research and to view CQC's Negotiator Guide to the Healthcare Concerns of Consumers, visit us at www.qualitycare.org/research. Thank you again, and I hope you enjoy the rest of the program.
Thanks again. That's a great discussion. And thanks again to Consumers for Quality Care for sponsoring this conversation. And now we've got an awesome panel. It's a time for our panel of experts. My good friend, Dr. Georges Benjamin, is the Executive Director of the American Public Health Association. Dr. Donna Christensen, a former member of Congress. She was the doctor before anybody was up there, first African-American doctor in Congress, and want to tip our hat to that. And now there are just so many doctors up there, a dime a dozen, but she was up there early. Former member of Congress who serves as a public health advisor to the Virgin Islands Department of Health, also a board member of Consumers for Quality Care, the sponsor of today's event. And Dr. Jalpa Doshi is a professor of medicine at the University of Pennsylvania. She's also the director of the Value-Based Insurance Design Initiatives, so important, at the Center for Health Incentives. And Samantha Artiga is the vice president and director of Racial Equity and Health Policy policy at the Kaiser Family Foundation. Big mouthful, everybody. Great to see all of you. Let me start out with Donna Christensen. Great to have you here. And I know that later we have Robin Kelly, who's going to be up there. And I know that you both kind of led the Health Brain Trust in the Congressional Black Caucus, which I think is such an important role. So as we think about expanding healthcare, expanding access to health insurance, and getting people onto a positive and constructive health track and addressing these inequities, Donna, what are the key pieces of that framing that are missing today that we really need to discuss? I think you're muted. There we go.
To address the inequities, you really need to address access and affordability.
Right.
And access means that for access, there are many barriers to getting the kind of care. There are barriers when you get in to the healthcare system because of the racism and the bias that exists there. Those need to be addressed. And then affordability. We've had so many changes, for example, to Medicaid, where caps, where individuals are dropped from the Medicaid rolls, benefits are cut. So we have to make sure that at least with that program, that it is expanded and we get rid of some of those barriers that have prevented people from being covered. We need to make sure that we address the exchanges. A lot of individuals who lost coverage went on Medicaid or went on the exchanges, but the cost is still too high. So we need to adjust some of the subsidies to ensure that we're really meeting the needs of people. So we need to make sure that there are providers there, access to providers, that those providers are of the community, that are humble and understand the community, and really we need to have more underrepresented minorities in the health professions. We need to utilize community leadership to connect people to healthcare. There are so many issues, but we also have to address the circumstances under which people live. If we don't change racism, and if we don't change the social, the economic, the environmental determinants of health, a lot of the work that would be done to provide access and to provide coverage would not be as effective.
I really appreciate you talking about the volume of challenges that are out there. I mean, it is a huge lift, and I think you're addressing it very directly. Georges, we've talked about this many times, and I would, just building off what Donna Christensen said, you and I have talked about parts of Greater Baltimore where you can go from one zip code to another zip code, and you've got 20 years difference in life expectancy. In a very little period of time. And so when you look at the structural elements of that, I mean, you've been at this, we've been friends for a long time. I just ask you, we're at a political inflection point in this country. Should we be talking about changing or revising the social contract around health and the patient? And what would be the key pieces of that for you?
Yeah, I think that we need to do this. As you, Steve, as you know, I practiced emergency medicine the first half of my clinical career, and then I pivoted into public health. And one of the things that I learned is that we are very, very good at putting people back together after they've injured themselves or gotten a very severe disease. But it's very costly at an enormous human cost. But we don't spend enough effort on the front end in terms of addressing those societal conditions in which people live. And the Congresswoman pointed out very clearly, and she's always going to be the Congresswoman to me, very clearly about the issues around the social determinants of health. If you think about how it played out in this terrible pandemic that we have, it was in many cases the lack of infrastructure in communities that's even today preventing us from adequately vaccinating individuals. It's the lack of providers in rural communities. It's the lack of education and knowledge. We call it health literacy, really understanding the healthcare in a culturally competent way. It's the fact that we have a system that does not have everyone in and nobody out. Even having that get in the system card, we all call that an insurance card, is extraordinarily important, because even when you give the vaccine as an example, or some of the therapies as an example for COVID, it doesn't guarantee that you're going to be able to get health care, because going to the doctor still requires some cost. And so we really need to think about the social compact in a bunch of ways around income inequality, on housing, transportation, access to energy. Look, the challenges that our colleagues and friends that live in the state of Texas today, look at the fact that they really haven't invested in the energy infrastructure and what's that done to its health. And if you really think about it, what they're not talking enough about is the disparities that's occurring in Texas, because there are people right now that were able to get up and go to a hotel. There are people that were able to get up and go to another place. And there's some folks who lived in communities where they're living in their car, where they're just using blankets to keep warm because of the loss of energy in that community. What would have happened had we invested in a strong energy security in the state of Texas? The health outcomes those folks are having right now would not be there in place. And the disparities that we're going to see as we begin to measure them, in a couple of days from now, hopefully when things heat up, are going to be, and we're terrible. And by the way, it was all preventable.
Yeah.
Powerful. Dr. Joshi, I know that you work around insurance programs and look at value-based outcomes, which I find such a promising and fascinating, track. But when you look at that and you're trying to design those initiatives, I guess I have two questions of that. One part is, how do you bring in the population that George's and Donna Christensen have been talking about into those programs so that they are included in part of that? And I got to tell you, the other dimension, I do a lot of healthcare moderating of, programs moderating. It's confusing to me, and I'm pretty well read. I mean, I'm just interested in the literacy demands for people that are not part of the health tracks that we need to bring in. What do we need to create, greater connectivity between patients in need and the healthcare system?
Yeah, sure. And so the most of the work that I do is in the context of prescription drug benefit design.
Right.
And I can tell you that we've seen from a lot of experience with, for instance, Medicare Part D, Steve, where Medicare beneficiaries really struggled when the Part D benefit was put into place, and the number of options that were being offered in terms of how do you go about choosing and picking the right options. And the type of populations that George and Donna were talking about, they clearly struggled much more in terms of making choices and evaluating which drug plans, formularies cover all the drugs that I need.
Right.
Which drug plans, formularies have the drugs that I need, but at a lower cost sharing that will cost, have lower out-of-pocket costs for me. And I think that this is an ongoing struggle within our fragmented healthcare system, where we don't have one single payer that has a single set of policies. And so it's patients who struggle trying to figure out. And as what I can also tell you, given all my work at the Center for Health Incentives and Behavioral Economics, is that human behavior tends to just stick with the status quo. So we have a lot of patients who are still continuing to stay in their plans that are probably not ideal for them. But if there's too much of a cost, I don't mean a monetary cost, but just a cost in terms of a search cost in trying to find out the best plan.
Do you see, Dr. Doshi, any model out there that's particular promising? I mean, this issue of how do you minimize and lower out-of-pocket costs. I've talked to Representative Doris Matsui about this at least 8 times. It's such, what you just talked about, Medicare D, the donut hole, the relationship with insurers and how to decomplexify that has been, an automatic part of these conversations for so long. But do you see any best and promising practices that you think we should highlight here today?
Absolutely. I think, as we just heard, even in the survey that was shown by the Consumer for Quality Care survey, the idea is that we are living in a system where we have patients who are facing really high deductibles, they're increasingly facing co-insurance as opposed to fixed co-payments. That means they're directly being subject to the percentage of the price of the service, or in the case of what I researched, the drugs that they're looking to get access to. And what we see is that there is a lot of barriers, particularly for Medicare Part D patients, because this is the population, the only insured population that does not have an out-of-pocket maximum. Even the health insurance exchanges under the Affordable Care Act have this type of protection for all its enrollees. But under Part D, or even under Medicare Part A and B, we are exposing our nation's seniors and individuals who are disabled to just unending, never-ending out-of-pocket costs. I think the low-hanging fruit here that I'd like to highlight today is the fact that there is an opportunity where Congress can act, and there has already been legislation that has been considered, and I believe 3 bills in Congress that were introduced in 2019 that have talked about introducing out-of-pocket maximum caps for the Part D patients. What I'd like to highlight, though, is that it's not going to be sufficient to just put in an annual out-of-pocket maximum. And this actually applies even for the non-Medicare, privately insured population, be it an employer-sponsored insurance plans or under health exchanges. Because that we have a system right now, as I mentioned, where we have patients who either face really high deductibles in the privately insured sector and the health insurance exchanges, and under Part D and other segments where they're being subject to co-insurance, what we are seeing is that patients are being subject to cost sharing that's like a roller coaster ride. And essentially, they face really high costs at the beginning of the year. The non-Medicare population who is fortunate enough to have out-of-pocket maximums will ultimately reach it and then kind of stop paying anything out of pocket. But the Medicare population is on this never-ending roller coaster, right? Because these benefits reset on January 1st.
Right.
And so I think we also need to pay attention not only to the amount of out-of-pocket costs that patients are paying, but the timing of it. And what we really need as an option which smooths out these costs for these patients, akin to what the energy companies do, helping consumers with payment options to smooth out high winter heating bills.
There is a lot packed in that. I'm really grateful for that outline of some avenues we can do it. Samantha Artiga, you are one of my favorite places. I love Kaiser Family Foundation. I read your products. I try to tool up when we're doing programs around this, and you deal with racial equity questions. You know, when I listen to Donna Christensen and my friend Georges Benjamin and how endemic these problems have been for so long, you know, it is one of these things where I ask, and I worked for Jeff Bingaman, a senator in the 1990s in the United States Senate. At that point, when it came to health care coverage, we had already done 13 major health care reform bills. But when you looked at the number of uncovered Americans in the 1990s, that you looked at the communities that were left out and marginalized, and this is 20 years ago. I guess my question is, we have the Affordable Care Act, but why? I guess my question is, you're obsessed with this topic. I'm just interested in why is it so hard to get it right in terms of getting all communities covered under a health umbrella? And what would you put on the table? You're at a smart foundation. What would you do?
So I think I'm going to be echoing a lot of the comments that we've already heard from the esteemed panelists that went in front of me. I mean, we know that health inequities have existed for years. They were in place long before the pandemic. The pandemic has really shone a bright light on those disparities, made more people aware of them, and is deepening them. And we are really at a very important point in time to address these disparities to prevent against even further widening going forward due to the pandemic. Certainly, health coverage is one component of the disparities we see in health and health care. The Affordable Care Act helped increase coverage across groups, But still, even with those coverage gains under the ACA, we see that people of color remain more likely to be uninsured, and that those gaps are likely widening as a result of the pandemic in terms of what we understand about trends and who's losing jobs and who's losing health coverage. There are a number of proposals at play now to expand coverage and make coverage more affordable, including some provisions in the Relief Act that would create incentives for some of the still holdout states to expand Medicaid to make the ACA coverage more affordable. And closing that coverage gap is going to be one really important component. But as my colleagues mentioned at the outset, the coverage is just one piece, and it's not enough. There is ongoing racism and discrimination in the healthcare experience that affects health outcomes. There's a large body of research that shows people of color receive poor quality of care. There are also access barriers that extend beyond health coverage, things like transportation, where providers are located, people's working and caregiving schedules. And then there are the broader social and economic factors that really drive our health. So we cannot fully address health inequities without also really doing the hard work of addressing inequities in these other areas like food, housing, transportation. So it's a big job, that it's cross-sector. It needs a long-term commitment with a broad focus.
Well, I really appreciate the way you framed it, Samantha, because that is, when I talk about whether or not, I often wonder, are we at an FDR moment where, is an opportunity in this crisis to reframe the social contract for more Americans? It raises the question. Just very quickly, because I do want to go to a question, I want to go to Donna and to George's and ask you. Donna, you tweeted recently, we don't have to make this partisan, but you said Republicans often refuse to make the significant and most effective investments needed in the care picture, in the health picture. Let me just ask you both, what are some of those investments that you think are vital for us to talk about today? Let me start with Donna and then go to George's, and then we'll take a question.
Let me talk about one investment that was included in a provision that was included in the Affordable Care Act that was never really funded. There was several, and it has caused a lot of hardship that could have been prevented. One of them was to improve and strengthen the public health infrastructure in this country. And it was never really funded to the extent that it needed to be. The community health worker grants. There was so many other programs that could have been funded, and so that's one.
But let me interrupt you, Donna. Let me interrupt you. Do you think because of the pandemic and what we're seeing, do you think there's a chance now to go back to those authorizations and get them funded now? Because I've heard from so many people what wobbly state our public health infrastructure was in. Do you think this pandemic changes the game on that, or are you pessimistic?
I sure hope so. No, I'm not pessimistic. I think the light that this pandemic has shown on the inequities and the weakness in our public health infrastructure compels the Congress and the Biden-Harris administration to really begin to address it. We used to talk about global health security and making sure that other countries had their public health infrastructure in place, and we really have neglected ours.
Georges, your thoughts on investment in putting the patient first?
Yeah, I would ditto the public health infrastructure for sure. But let me just say, I think at the end of the day, we got to build a system with everyone in and nobody out, and we have to make it affordable. One of the many ways we can also make this affordable is by making sure that we get to the minimum wage and get to a wage that can everyone that can work and not be in poverty. There's a strong correlation between poverty and poor health, and it is so strong that if we reverse that, it would make a tremendous difference in our ability to be affordable. Now, we can't make it regressive. In other words, we can't make all that money then go into a healthcare cost structure that's out of control, which our healthcare cost structure is out of control. But I do think that at the end of the day, making sure that that everybody was in effect a living wage. And I know that's different from a minimum wage, is going to be very, very important.
Well, look, I mean, each one of you, I think, has done a very good job of talking about the synergy between these different factors and how you kind of address both inclusion, but the real costs, as you know, Dr. Doshi just shared, as you all have shared. Let's take a question now. We have a question from Amy. Amy?
I'm Amy Niles, Executive Vice President with the Patient Access Network Foundation in Washington, D.C. We worry about the rising out-of-pocket costs for prescription medications, especially for Medicare beneficiaries who are living with chronic illnesses. What are the Medicare Part D policy solutions that could help lower these costs?
Let's do round one. Let me just start with Dr. Doshi for that. Dr. Doshi?
I think there are several options on the table. As I already mentioned, clearly the first lowest hanging fruit that Congress must act on should be instituting a maximum out-of-pocket limit for Medicare beneficiaries under Part D. The costs that patients with chronic illnesses and serious life-threatening diseases which need to be treated with expensive specialty medications result in too much of an out-of-pocket burden. But the second piece is that given the Medicare Part D design, this too much out-of-pocket burden also happens to occur too soon at the beginning of the year. So a cancer patient who needs an oral anti-cancer medication with $10,000 in total out-of-pocket costs in the year would have to pay $3,000 for their very first prescription. So clearly Congress needs to do something to allow smoothing out these costs for these patients who are typically on fixed monthly incomes. And these costs for single prescriptions, not just for cancer, but for MS or RA drugs are sometimes one and a half, two-folds, three-folds of the average Social Security income. The third option, which I think would also address some of the inequities that we've been talking about here, could be to be more nuanced and not treat all patients alike. And current bills that were floated around in the Congress around annual out-of-pocket maximums had a single limit. But let's think about income-based annual out-of-pocket maximum limits. Let's think about income-based monthly out-of-pocket limits. Fourth, I think for specialty drugs, we could potentially consider not requiring all drugs that CMS does right now that exceeds a certain threshold, about $700, to be placed on these really high cost sharing tiers called specialty tiers. And perhaps cost sharing should be tied to the value of the drug that the drug provides, as opposed to just having a high cost sharing applied to all these really important medications that might be necessary for many of these patients.
Terrific, thank you. We have, we're almost out of time, but quick thoughts, Samantha Artiga and Donna Christensen and Georges Benjamin. Samantha?
Well, the past administration expanded on the copay adjustment so that the copay coupons don't count towards the deductible, and I think that's a real low-hanging fruit that needs to be corrected as well. That might help to reduce the cost.
Terrific, thank you, Samantha. Do we have some?
I don't have anything specific to add other than to just, reinforce that costs and out-of-pocket costs really impact people's ability to access care. And we know from the research that low-income people in particular are very sensitive to out-of-pocket costs, and that it has real impacts on whether people are getting the care and services they need.
Really appreciate that. I'm going to give the final word to Georges. George?
Yeah, look, at the end of the day, if we're really serious about controlling costs, then we need to start looking at some new models like we have in Maryland, the state of Maryland, our all-payer system in Maryland, or frankly, doing more around letting the federal government negotiate within some limits for prescription drugs. At the end of the day, the cost of all of our care, particularly pharmaceuticals, is way too high. And if you don't pay for your medication, then we always pay for it in someplace else. And we just don't ever capture those costs.
Well, look, it's been a fascinating conversation. One of these days, I don't know if you remember the old Fred Friendly seminars. Fred Friendly would be on there, and they'd have U.S. government officials oftentimes saying, it was about dealing with nuclear war, but they would have different agencies represented. I want to someday be the host of that with everyone in healthcare, the insurers, the pharmaceutical firms, the public health associations, the patient advocates, the Kaiser Family Foundation, everybody, and simulate a way to eventually address some of these inequities. And I hope you'll all come back when I get the chance to do that. It's been a real pleasure to talk to all of you.
Thank you, Steve.
Thanks.
My final guest is Congresswoman Robin Kelly of Illinois. She serves as the chair of the Congressional Black Caucus Health Brain Trust and is the vice chair of the Energy and Commerce Committee. Congresswoman Kelly, it's great to see you. I just enjoyed having Donna Christensen on, and she held that job, way back. So let me just ask you, as you look at what we've been talking about, which is getting fairness, equity, and just getting more people covered with insurance that doesn't wreck them financially. What are the things on your radar screen that the government or other players out there in the private sector ought to do in terms of revising that social contract and bringing people more into healthcare that they can afford, sustainable healthcare, really?
Well, it was very good to see my predecessor. I was scared to death to take her place since she is an MD, but I'm still learning from Dr. Christensen. I really think that, we need to look at our healthcare system as a whole and a lot of the things that your panelists just said. Now, I couldn't remember if they said something about telehealth, because I think that telehealth could be the great equalizer if done correctly, especially as far as access. And I've spoken to constituents that I have, and they say how much it saved them time. They've been able to keep their appointments. They don't have to miss work. They don't have to miss school. And I've spoken to many doctors who have said that, and a lot of African-American doctors and doctors of color that said that their patients are able to keep their appointments much better, than in the past. But as was said, COVID has shown such a light on the disparities. The numbers that we see may be shocking, but they're not surprising because the disparities have been with us forever.
Well, let's go a little bit deeper on that. We have Leslie Krigstein, who's Vice President of Government Affairs from Teladoc Health, who sent in a question. He says, how can virtual care, meaning telehealth or remote patient monitoring, which I've discussed a lot with folks, particularly on diabetes, improve efforts to put the patients at the center of their care? You began to get into some of that, but I remember before the pandemic hit, we talked about telehealth. And, there was a lot of skepticism out there until, everybody came in. So as we discuss putting the patient first, is this a blind spot that's finally been removed, that now there's a new platform out there that actually begins to create new competencies and the ability to put the patient at the center of this process?
I don't know if there was a blind spot. There are places in my district. I have one of my hospitals, and I'm urban, suburban, and rural. So some of my rural hospital has been using it as one of my social service agencies when it came to mental and behavioral health. I am married to a doctor that had never experienced telehealth until COVID happened. He actually makes home visits. He goes into the home of senior citizens. And so he has used it now because he can't go into the homes, So, maybe after he gets his second shot, he can. But I do think, just from hearing his conversations with some of his patients, they do feel at the center of attention. And initially, the comments were, oh, you still care about me? Oh, you're calling me? Oh, I can still have contact with you. So I just think, especially with seniors, the idea of someone calling in or Zooming in or however the telehealth is done, it sends a powerful message. Some of them are by themselves, and my husband is the only one, that they may speak to in a week.
Congresswoman, there's another dimension to this. I love talking to you. I can tell you're having fun, and I love your tweets, by the way. So glad your mom got vaccinated, and you were celebrating that. But part of the reason folks like you are showing that is that there's a distrust out there in some communities, that oftentimes we're talking about communities that have been marginalized. We talked with Donna Christensen, who said, there's a lot of systemic racism built into this. We don't have communities of color built into the doctors' healthcare systems to the degree that looks like America. And so part of the strategy has to be to talk about trust, right? Part of it is cost, but part of it is trust. And that's hard to legislate. But I'm interested in what you think we can do on the trust side of the equation about vaccinations and about believing that the healthcare system that we have in place is not stacked against the patient.
Well, it's going to take a lot of work, and it's something the Congressional Black Caucus Health Brain Trust, the Congressional Black Caucus Foundation, there's a Black Health Group Against COVID. There are many of us working on this issue. In fact, I was on a national forum today. I'm going to do a local one tonight. The Congressional Black Caucus is going to join in with other partners to do something in March. We're going to keep talking about this to educate African Americans, but people of color in general about the vaccine hesitancy, that they have. Now, I don't think you can legislate this in particular because, of course, you can't make a person take the vaccine. But I think the more we can educate people, the more they meet people that have already taken a vaccine, like I've had both of my shots and I'm okay. The more we can expose people to that, but also going forward, we have to diversify the healthcare field. We have to teach differently in the medical schools. I mean, we have to consider, I hate the word cultural competency, but I don't know how to describe it, but there's been many documented reports that people do better when it's someone that looks like them or at least understands the reality of their situation. So, we're not going to just wipe away the trust completely. And I know people don't have trust even, in government also. That's part of the problem. They're concerned about, they think the vaccine, was created so quickly, just a lot of different things. But we answer as many questions as we can and try to get people comfortable. And again, try to identify ambassadors in the community that people feel trusted and comfortable around.
I couldn't agree with you more. And I just, I want to be snarky for a minute. I mean, this is something I discussed during the Trump administration with people like Dr. Anthony Fauci, Dr. Robert Redfield, Stephen Hahn at the FDA, and saying, is there a communications plan where you're able to go identify and even hire or, get pro bono participation from, standout people from the different pockets of America and use them as ambassadors to talk to them and said, oh, don't worry, we've got the communications plan taken care of. It'll be fine. It'll be fine. But, when I go to Minnesota and you talk to Native American communities there, you go and talk to Latino communities, you go down to Baltimore, where I've interviewed a young lady with all sorts of health issues in her family and talk about what it would take to get her neighborhood vaccinated. She said it would really be nice to have someone we trust or know or look up to talk to us. So I guess my question is, I agree with you 1,000%. Do you see the Biden administration making any bigger steps on finding those ambassadors than the Trump administration did?
I definitely do, because I am on energy and commerce, so I know there's resources put in the pot to grow the community healthcare workers. Those are people from the community that will deal with people in the community. There's money to build up the federally qualified healthcare centers. So I do think, there's a plan, and we voted on getting that plan, our part of the plan, out of Energy and Commerce last week, and it was submitted to budget this week. So I think that President Biden and Vice President Harris are very aware of some of the things that we must do to deal with disparities in healthcare.
Congresswoman Kelly, let me ask you a complex question. I had somebody last night who's a friend who's in this network of quality care and wanting to put patients first. He said, Steve, there's so many things going on in the sandbox of healthcare that no one's writing about. I don't want to mention the company that he mentioned, but he said there's an insurer that's becoming like the Apple computer of health, that is hiring more physicians than anyone else, that has its own PBM, and that these all change the winners and losers in the network. and no one's writing about it or where. It's a different type of topic than just looking at the question of how do you afford, expand affordable health care and deal with out-of-pocket costs. But it's the broad side of how do you keep all the players in a balance that's producing the best outcomes for the patient. I guess as a legislator, are you folks aware of some of the business changes that are going on and what their potential impacts on patient care might be?
I do think that there's just so much, as you've just said. Right. And I think that as a healthcare subcommittee and other committees too, like oversight, we try to stay abreast of everything. There are just so many issues. And you saying that will have me speak to Chairman Pallone or Chairwoman Maloney that we have to look out, for things like this. So we have to keep calling companies in or, witnesses in, whoever we need to call in to make sure that there is a balance and there is equitable treatment.
Well, Congresswoman Robin Kelly, chair of the Congressional Black Caucus Health Brain Trust, of course, from Illinois. It's been a real pleasure to talk to you. Anytime I can help you, and anytime you have a good 800 words, you want to kind of share an idea with us, send it my way. And I'm happy to run it in the Hill. But thank you so much for sharing our views. And I think this is a real vital discussion. I know we're going to be at it some more, and I hope you'll come back.
Definitely.
That brings us to the end of our program today. A big thank you to Consumers for Quality Care for its support of these conversations and to all of you attendees for joining us for this discussion. For those of you who missed any of the conversations, we're going to have the video up of the entire event on our website shortly. I'm Steve Clemens. Stay healthy. Be well.